friends. This is our third online panel. We will today discuss two great topics. One will be on brachial plexus surgery, which is in collaboration with Peripheral Nerve Surgery group of WFNS and Young Neurosurgeons group. We will be together for the next 3 hours. Then after a 30 minutes break, we will have a trigeminal neuralgia management panel with very distinguished members, speakers. I give the words to Dr. Debora Garozzo for moderating this session, first session.
Thank you so much. First of all, I really would like to express our happiness for being invited to participate in this webinar today. And I really have to say a big thank you to Professor Mehmet Zileli, Chair of the WFNS Education and Training Committee, for giving us this opportunity. I think I can also express the feelings of my colleagues here. We really wish that this is going to be the first of a very long series of webinars and activities organized in collaboration with the WFNS Education and Training Committee. Today, I think we are going to have a very interesting session because we are going to talk about a very challenging topic, that is brachial plexus surgery. We have 3 speakers. The first one is Christian Heinen, who's going to talk about brachial plexus anatomy, but he will introduce concepts that are of practical use. Then I myself will talk about thoracic outlet syndrome, that, as you know, is a very controversial entrapment syndrome. And then we are going to deal with a hot topic, which is the management of brachial plexus injuries. And this is going to be done by Amit Thapa from Nepal, who has been a trailblazer because he is the one that actually has introduced brachial plexus surgery in Nepal. So I do hope that everybody is going to enjoy this session, and I think we should probably start with the first speaker.
So, since the program says to start with the brachial plexus anatomy, it's my huge pleasure to be part of this team and to share, well, some of mine and some of other friends, as you will see, experiences with the brachial plexus anatomy. I want to thank Professor for inviting us, and of course Debora for setting this up. So we will start with the anatomy. I hope everybody can see the screen. Since large parts of this talk is based on something that Mariano, who was already mentioned, Professor Sokolowski from Buenos Aires, did in his work, and he permitted me to include this into this talk, I credited him right away. So it's basically German-Argentinian co-work. I have nothing to declare. And the major aspects of this talk will be: one is the fantastic book by Mário Sequeira and Roberto Martins. It's in Portuguese, but if you can ever get hold of it, it's a piece of art. It's the most brilliant and most perfect anatomic dissections that you will find. I will apologize in advance for the quality of the scans, but there's nothing comparable out there. And this is Mariano from Argentina. This is Fernando from Rio. Daniela from, well, from Argentina now. She's working and living in Germany, and myself. So basically, we have Debora here, we have Lukas here. So it's a group of friends that happen to share the same passion. And this is what the plexus anatomy is also about. You need to have friends to guide you somewhere. So everybody knows these schemes of brachial plexus. You have usually the 5 roots, T5, 6, 7, 8, and T1, that later on form this very complex construct of the brachial plexus. The ones that you will encounter surgically as the first are the 3 trunks and the 3 cords. So these 2 are your friends. And from there on, you will start to explore the rest of the brachial plexus. The trunks are situated, as we all know, supraclavicularly, as the cords are infraclavicularly. So you must imagine here the virtual clavicle. So when you open up, and fortunately or unfortunately, in the recent literature, brachial plexus exploration has more or less been omitted because of the alleged successes of the nerve transfer. But we lose great opportunities and great options, both in functional but also in pain management, if we don't explore the brachial plexus. And of course, therefore, you need to know and you need to get acquainted with the brachial plexus anatomy. So as you can see, you have the three trunks that each of them have an anterior and a posterior division. So this makes 3 divisions. And what is common is that all the posterior divisions form the posterior cord. So post. This is something that you can easily remember. And for the rest, we will go through this and everybody can, you have the schemes in mind. And in the end, you have 5 spinal nerves that they derive from, and you have 5 terminal branches that they end up with in. So you have 5 in the beginning, 5 in the end, and in the middle, it's important to know that there are 3 friends that you need to stick to. This is just a short overview of all the muscles that are supplied by the brachial plexus. Of course, there's a huge variety in individual anatomy, and this is something that you need to keep in mind necessarily. So just because you learned it in the books, it will not match your surgical reality. So what is important, and we will have this later on in the talk about costs and also in the talk about the management of brachial plexus injuries, that you of course need to define in each individual patient how the respective connection is and how the respective innervation pattern is. And the same is for sensory. So you have the dermatose that you all know when you treat spinal patients, and if you turn this into a more plexus and more peripheral nerve-based view of the things, you will find these innervation patterns that, of course, are highly individual too. But like the target muscles for C5 is deltoid and C6 is bicep and so on, you will find similarities for the sensory innervations. So it makes sense, and this goes also for us experienced nerve surgeons and brachial plexus surgeons to go back to the books once in a while just to reassure and reconfirm of that what you know and what you think is true is really true. Or maybe you will find cases that you need to go through all over because nothing is the way that you thought it was. As maybe you've heard of the so-called prefixed plexus. So this means it doesn't start at C5 and goes to T1, but prefixed means it starts at C4 and goes to C8, as well as postfixed means that it doesn't start at C5, but at C6 and goes down to T1, T2. So these are things that you will encounter, and these are things that you need to keep in mind to be able to treat your patients properly. So let's start with the supraclavicular approach. As we had heard before, even here you need friends. So if the patient is laid on the OR table, usually we tilt the head slightly to the opposite side, and then we identify, of course, the clavicle, and we identify the external border of the sternocleidomastoid muscle. These are the 2 structures that are, elementary for getting to the plexus, and this is where the incision usually is placed. So this is from the book of Mario and Roberto. So this is medial, this is lateral, this is cranial, and this is caudal. And what you see is that you have the sternocleidomastoid muscle, and when you open up, the first thing that you find is the platysm, and you open that up, you will find the external border of the sternocleidoid muscle, and you have the external jugular artery, vein, and of course the cervical plexus, not to confuse with the brachial plexus. Some people say cervical brachial plexus. This is something that is not existing. So they're two different entities. So first step is open the platysm, find the external border of the sternocleidoid muscle, and open up the cervical fascia. And the next muscle that will lead your way to the plexus is orthogonal to the sternocleidoid muscle. It's the omohyoid muscle. So this is important in two regards. First, to guide you to the plexus. And second, if you follow it distally, you will be able to follow up the suprascapular nerve, which, as we saw before, is part of the brachial plexus. So this is already the deep fascia open, and you will find this fat body that is covering and protecting your plexus, is helping the plexus to glide. So you should be very careful with it and not cauterize it as much as you can, but just detach it on the medial border and then flip it around to preserve it, and later on to be able to use it again to cover the plexus. Once you have identified the omohyoid muscle, you go next step, as the authors did here, and you pull it upwards, to open up the space. And then the next muscle you will find is, so this is again a sternocleidomastoid muscle. You see both scalene muscles, the anterior scalene and the middle scalene muscle. And what makes you surely identify the anterior scalene muscle is that the phrenic nerve is running along it. And the easiest way to be sure if this is not a vessel or not a lymphatic duct or whatever is to use intra-op stimulation. So once you identify the anterior scalene muscle and you see a nerve and you stimulate and you have diaphragm contractions, or if your anesthesiologist starts to complain, you know that you are right. This is so the phrenic nerve and the anterior scalene muscles are your next friends, because it's easy to find it. Usually going down to the clavicle, you will easily find it. If you go cranially, which is this direction, you will end up in C5, and you will end up at the lateral border of anterior scalene muscle and the middle scalene muscle. So this is what you call the interscalene triangle. This is actually it. This is actually it. So from there on, you know that you're in the level in the surgical plane in which you should find the plexus. So from that on, well, you need to be careful and meticulous all the time, but from that on, you need to be even more meticulous and more prepared to encounter nerves. So this is taking you to the next step. We see that the structures have already been dissected out. And as you can see, as I said before, this is what you find first. This is what you will see first. These are the trunks. So usually you don't start operating or dissecting proximally where you find the spinal nerves, as you see here, C5. So we came all the way up from the phrenic nerve and we found C5. Then we go down and we see the superior trunk that is formed by C6 and C5. And the first branch of the supraclavicular plexus of the superior trunk is the suprascapular nerve, which is this one. And the branching pattern is different or can be different. You have an anterior and you have a posterior division. Then you go more caudal and more medial, and you will find C7 and the middle trunk. Then you move like climbing a ladder. You take the next step, and you will find the inferior trunk with C8 and T1. And of course, and you know when you're headed caudally enough, when you find the subclavian artery, which is of course easy to identify or to palpate. And I'm talking about normal anatomy now. I'm not talking about brachial plexus injuries. This is something that maybe you would find when operating on a TOS. So you have clear anatomical structures guiding your way. So sternocleidoid muscle, mastoid muscle, omohyoid muscle, which is protected, anterior scalene muscle, phrenic nerve. You find the plexus, you find the middle scalene muscle, you find the subclavian artery, and you have the clavicle. And from there on, you will develop all these plexus structures. And as you going back to this one, as you find here, the first real plexus structures that you will see are the trunks, are not the spinal nerves usually. So this is video from Mariano. You see the muscle, you see the phrenic nerve, you see the, so the phrenic nerve is now grabbed, you see the anterior scalene muscle, and you see that what in the next videos will become the plexus. You see here the anterior scalene, the sternocleidoid muscle retracted. So to open up the view on the plexus, which of course in surgical reality you would not do, to remove the sternocleidoid muscle. So next video, zooming in, you see phrenic nerve, anterior scalene muscle, you see the superior trunk, and not right visible now is the suprascapular nerve will exit here, and somewhere here down will be the clavicle. And this is telefixed caliber. So you see the difference to the fresh frozen or to reality. So now, once you saw and once you detected the plexus, you want to know the exact individual anatomy. So now it starts that you will find and go up for C5, following it all the way up to the foramen, same for C6, for C7, and especially in TOS, you want to know what about the inferior trunk, which is the most affected nerve structure during in TOS. In this case, the authors, as you can see here, detached the anterior scalene muscle. So you see how close, this is the internal jugular vein. So you see how close all the structures are. Again, phrenic nerve, this is the pleural cupola. So you're on the lung, you need to be aware of that too. So it's a very interesting, a very beautiful region, but it's also a region that you can cause damage and severe damage. So you need to keep in mind that you're working in a very delicate field. Once again, shown in the video, the individual structures. So you see here the suprascapular nerve, superior trunk, phrenic nerve. Posterior division, middle trunk appearing. This is middle trunk. Fantastic voice of Mariano. And then you will see the inferior trunk, and down here are the vessels. Is the subclavian artery. Okay. So now we dissected out all the suprascapular plexus, and believe me, it can appear and seem very easy, especially if you have these fantastic images that I just tried to show you. But to be able to do this in reality is that you need to respect the layers that nature offers you. And once you do that, first, you can do little harm. And second, you will be very straight forward and very clean to find and dissect out the brachial plexus. So the second is the infraclavicular space. And again, I apologize for the quality of the scanners. So this is deltoid muscle. This is the pec major, and this is the fossa. So now here, the pec major is retracted, the deltoid is retracted, and what you find next is what is here marked with the loop is the pec minor. And already underneath, you see this fat body that is covering, again, the infraclavicular plexus in the same way as the supraclavicular plexus is covered by the fat body. And again, this is something that you definitely need to preserve. Don't counter it, don't take it out. Just detach it, flip it medially or wherever you want, but don't leave it pedicled, don't kill it. So again, the video, so pec major is marked, pec minor is now reflected. And once you're underneath the pec minor, you're on the plexus. So this is what you know. So you can move quite fast once you're above pec minor level. Once you get underneath pec minor level, you need to be very careful because then you will be in the infraclavicular plexus. Yeah. Okay. So again, here, as you see, pec minor is detached. It's flipped medially with the preservation of the pectoral nerves. And once you flip it back, you will find, again, your three infraclavicular friends, which is lateral cord, posterior cord, medial cord. So again, supraclavically, you have the three friends of yours, are the three trunks. Infraclavicular, your three friends are the cords. And from there on, you can develop the divisions, you can develop the terminal branches. But if you, once you identify the cords, you will be safe and you will understand what's the deal. And you need to know that the names of the cords derive from their position to the axillary or subclavian artery. So the lateral cord is lateral to it, the medial, and the posterior. It's very simple, but sometimes these simple things save your, save you and your patients when you remember it. And intraoperatively, especially in traumatic cases, see, okay, where's the vessel and where are my cords? So that's the way when you're not sure to identify the structures. So once again, this is pec minor removed. You see the lateral fascicle, which is always the first one that you encounter, and you see the vessel here. So this is muscle. I will stop it here. So lateral cord, musculocutaneous part, and the part that goes to the median nerve. And this is the artery. So we are lateral to the artery, okay? So lateral fascicle. And as you can see here, the musculocutaneous nerve, which in reconstruction is crucial because you want to give back arm flexion. That's the only nerve that leaves the compartment in which the other vessels and nerves run in, but it enters the brachioradial muscle. As you can see here. So this is how you identify the MCN. I'm sorry, the coracobrachial muscles. That's how you identify the MCN. It's entering the muscle, and then you know it's the MCN. Okay, keep that in mind. It will help you a lot to identify the nerve. Moving to our next structures. So we identified lateral fascicle. We identified MCN. We identified the median aspect of the MCN. Again, MCN, median nerve, and this is the artery. Okay. And here you see the medial fascicle, medial cord. Yeah. And this is just by flipping back the pec minor. Okay. So, of course, we want to know all the structures. So that's why we retract the lateral cord, we retract the arteries, and then we see the posterior cord, this one, that goes to the quadrangular space, which is the axillary nerve, is the deepest nerve of the infraclavicular plexus. And we see the radial nerve that goes down further down the arm. So with that, and you see there's not a lot of manipulation done. you will find and identify your structures. Once more, posterior fascicle, axillary nerve, radial nerve, and just by retracting gently the structures. So this is what I wanted to show you with this brief introduction to brachial plexus anatomy. And it's worthwhile to get into books. And if you have any chance to get your hands on cadavers, just go for it. And this is the team that I'm blessed to work with. And thank you very much for your attention.